Good morning, everybody. Nobody hear me.
Yeah, you can be heard.
Yeah. Hi, we're going to start the plenary session this first day. Welcome all of you for sharing your time with us. We're really glad to have this plenary with you and with two amazing doctors that are here waiting their moment to speak. I have here Dr. Edward Nardell, and please.
How do I get the slides? There are slides for this session that need to... Plus... Oh, escape. Ah, okay. Very good. Thank you. The reason I'm standing before you now is that I had the great pleasure of knowing Richard Riley very well in the last 18 years of his life. We worked together. And even though I knew him quite well during that period of time, I had no idea that he had been not only a major contributor to our knowledge of tuberculosis, as I'll briefly mention, but also a major contributor to the Union, including in his bequest upon his death. So the Union was quite anxious to establish an annual symposium in his name, and I have the great privilege of telling you a little bit, particularly the younger people in this audience, of who Richard Riley was and why his contributions were important, and then to introduce the first of the two speakers today. So Richard Riley actually had a dual career as one of the first major pulmonary physiologists working at Columbia in New York, and then going on to be chair of environmental health at Hopkins in Baltimore, where he really focused on public health and harkened back to his early days. And what you see here, I don't see a pointer, but is a picture of Richard Riley late in his life. I took that picture in his home, and he's sitting at a harpsichord that he built. He was really a very accomplished musician, and holding a photograph of William Firth Wells, the Harvard engineer who really first measured airborne organisms in the air. And in his books, he credits Richard Riley, a medical student at the time, with the concept of droplet nuclei, that the way organisms might get from person to person would be the evaporation of particles that become then airborne. Now, to prove this, Wells envisioned an experiment which Riley carried out later in life in Baltimore, which is pictured here. And you see one of 6 beds where patients were occupying the room, and the air was circulated up to a penthouse where hundreds of guinea pigs breathed that air. And at the time, in the late 50s, early 60s, it was not certain how tuberculosis was transmitted from person to person. After all, whole families were impacted, and there was even a serious thought that there was a genetic factor and a disease. But it was suspected to be infectious, and this experiment, the only contact between the patient and the guinea pigs being air, proved that in fact TB was airborne. The other things that he showed in that study, so it was a droplet nucleus concept of airborne transmission. He quantified it and showed that there was enormous variation from person to person in how infectious patients were, that there were disseminators, and then there was everybody else. And this had many factors to do with it: the strain, the host, the cough, and some we don't even understand, the strain of organism. And he showed that infectiousness was extremely rapid, that the institution of therapy stopped transmission extremely rapidly. And it took me many readings to realize how rapidly. It was, if you read the paper, which, by the way, is reproduced as a classic in 1995 in the American Journal of Epidemiology, and another one that follows, you'll see exactly how rapid that was. So we've had the good fortune of reproducing Riley's facility in South Africa, the Airborne Reinfection Research Facility. So in many ways, Riley's work goes on. And I've been in close touch with Riley's family ever since I've known him. And I want to give you one little quote here, and I'll stop. Saul Permit was one of Riley's first fellows in physiology and remained a close colleague even at Hopkins. And he quotes Moran Campbell, another famous physiologist, who tells this story. After being in Riley's laboratory for a few weeks, fresh from his intense training in physiology with Samson Wright in England, he and Harry Martin presented to Riley some tracings of the relationship between flow and pressure on a forced expiration. Riley came back to them a few days later with his hands filled with lots of graphs, his mind filled with lots of new ideas, and his heart filled with great enthusiasm. That's Richard Riley. Moran was shocked. I've not been brought up to extrapolate wildly from preliminary findings using equipment of questionable reliability. Riley, if that's the case, you've come to the wrong place. I've spent my whole life doing just that. So this was a man of great enthusiasm, and not every idea was right, but many of them were. Now it's my great pleasure to invite to give us his talk Dr. Uplekar, who is a senior medical officer in the policy strategy and innovations in the unit of the Global TB Program at the World Health Organization. He began in private practice, which is very important for the talk you're going to hear about, because he has really then switched to international public health and has devoted his career to the extremely difficult problem of the public-private intersections, particularly in India and other parts of that, other countries in that part of the world. And so he's going to talk to us today about private partnership? No. I apologize for that. I should have read what was said here. At any rate, it's WHO's new NTB strategy. Thank you very much. I was so focused on Riley. Sorry about that.
So thank you, Ed, for the introduction. I think I'm stigmatized because of my PPM work. I must also thank the union for giving the Global TB Program this space to present the new post-2015 Global TB Strategy. I would like to begin with a disclaimer that what I'm going to present here is a product of collective work that many of us have been engaged in preparing for the last 2 years almost. And when I say many of us, I don't mean just the WHO-wide team, but many of you as well. I mean, many of you, from program personnel to partners, and from activists to academics, have all contributed to shaping this final product. Now, on 19th May this year, at about 6 in the evening, after more than 50 member states took the floor to make statements, all in support of it, the World Health Assembly unanimously passed a resolution which adopted, without any major changes to the draft proposed by the WHO Secretariat, the post-2015 Global TB Strategy. And from that moment on, I must say, it no longer remained only WHO's strategy. It is a strategy of everyone who is concerned about TB care, control and prevention. Since all governments have now endorsed it, There is no going back on it, and we may say that it is cast in stone. And since this is going to be our common strategy for a long time to come, I think it is reasonable that we should all try and know it by heart. So can we keep that as an objective of this plenary and try to achieve it? To help us absorb it well, what I'm going to do is try and keep on the screen the contents of the one pager that you see on the right for most of the time of my talk. I would like all of us to embrace the new strategy along with its new name, the NTB strategy. Now, why NTB? Well, I would like to park this question for now and come back to it shortly. Well, it is important to first understand that the NTB strategy has not come out of the blue. It's a very logical and necessary extension and expansion of the work that we all have been doing for many decades, I would say. So as you see here, the NTB strategy is built on the foundations of both the DOTS and the Stop TB strategies. The 5 components of DOTS, they all merge to become the very first component of the Stop TB strategy. And the whole Stop TB strategy gets incorporated into the NTB strategy, which goes much beyond. So this is how the NTB strategy looks like at a glance. And this is what we should try and remember to the extent possible. The strategy has a vision, goal, milestones, and targets that tell us what we have to achieve incrementally and ultimately, while its principles, pillars, and components tell us how all this can possibly be achieved. So let's go over the top half of this one pager, line by line. The strategy has a vision of making the world free of TB by achieving 0 deaths, disease, and suffering due to TB. Now, there was some initial reluctance in accepting these zeros, and for pushing them through, we all must thank our activist colleagues and friends. Because in the world of TB, they are a rare breed, and they deserve big compliments for pushing us all in that direction. Now, the goal of the strategy is to end the global TB epidemic by 2035. Now, what does that mean? Qualitatively, ending the global TB epidemic means bringing the problem of TB in the whole world down to the levels that most of the rich countries have already reached. While TB has not disappeared from the rich countries, it no longer exists in epidemic proportions. And that is what is meant by ending the TB epidemic. And in quantitative terms, for the targets, it means reducing TB deaths globally by 95% and reducing TB incidence by 90%, which converts to less than 10 cases per 100,000 population per year. Now, the third target is an attempt to measure the reduction in the invisible effects of TB on societies. No affected families facing catastrophic costs due to TB is a proxy to measure alleviation of socio-economic suffering of the patients and households and enhancement of equity in access to TB care and prevention. The strategy also gives milestones for 2020, 2025, and 2030 on way to achieving an end to the epidemic by 2035. And we have taken only a midpoint for this summary page. But if the post-2015 Sustainable Development Goals, as they are likely called, have 2030 as the end date, and we think they do, and if TB remains a health goal, and we do hope it will, then we may have to first set our sights more firmly on that date. Now, unlike the previous strategies, the NTV strategy has some key principles. Now, these are called principles because they are critical, they are cross-cutting, and they apply commonly across all components and pillars. Now, they have therefore been elevated and placed above the pillars and components of the strategy. Now, the first two principles, all these principles are pretty self-explanatory, I would say. The first two principles we need to appreciate, that the governments must be the stewards and be accountable to progress in TB care and prevention. But governments must not be the sole implementers of the strategy. All stakeholders have to be on board and have to be fully engaged. The third principle is about applying a rights-based approach to implementing the strategy, maintaining the highest ethical standards, and progressively reducing inequities. And these are critical imperatives that all TB programs must embrace, and I don't think there can be two opinions about it. The fourth principle is about adaptation. And what does adaptation mean? Well, in simple terms, it's mean adjusting and prioritizing interventions on the basis of a comprehensive view of a country context, considering at least the national and subnational epidemiology of tuberculosis, the characteristics of the health system, the performance of the TB program, and certainly the demand-side characteristics such as the social and behavioral dimensions, especially of the affected populations. And a first example and a good demonstration of adaptation has already been produced, and those who were at the Global TB Symposium saw this, the document on adaptation of this strategy to low incidence countries. Now we come to the action part of the strategy, the pillars and the components which form the substance of the NTB strategy. Now the pillar 1 is about the core business of TB care and control, care control and prevention, and it's also the main pillar of the strategy. On the ground, however, the effective implementation of pillar 1 will be possible only if it is supported by systems that enable efficient implementation and management of TB care and prevention programs, and these may require not just a number of enabling policies, but also their effective enforcement, which is often the weakness. And this is what exactly the pillar 2 is about. Now we know what generally puts a big burden on the health systems when it comes to TB care, control and prevention. Besides the peculiar nature of the disease, it is the age-old tools of care and control that we have to be content with that really make things burdensome. It takes too long to diagnose TB, it takes much longer to cure it, and there is very little to prevent it. And that's why we need the third pillar dedicated to research and innovation, and to develop not only just the new tools, but also new strategies of implementation. So you now see a clear logic in the design of the three pillars. Pillar 1 is the core, the fundamental, and it is our main business, but it will be possible to implement it properly only with a strong pillar 2 in place. And further, however well we may do with pillar 1 and pillar 2, achieving the ambitious target set under this strategy of seeing an end to the TB epidemic in the foreseeable future will not be possible without innovations and the new tools that are expected from the pillar 3. Now, if you ask me what precisely is new in the new strategy, here it is. So all that is in blue is new. So every pillar and component has something that we have not been doing at all or not doing well enough all these years. And I don't think I need to explain all that is very clearly and explicitly mentioned, not just here, but in the strategy document which is available on the WHO main website. Rather, I would like to focus on a few key messages that are implicit in the design and description of the pillars and the components. And these messages may also probably help in answering the question that we parked in the beginning. Why call it the NTB strategy? In a way, the name NTB strategy seems pretty logical. Because let me put a question to you. If a strategy that is meant to stop the TB epidemic is called Stop TB strategy, what should the strategy that is meant to end the TB epidemic be called? Because mind you, while the TB-related Millennium Development Goal is to halt, that is to stop TB and begin to reverse the epidemic, the TB-related Sustainable Development Goal, as it is drafted now, is indeed to end the TB epidemic along with epidemics of HIV and malaria. But there is more. It's not just what's in the Sustainable Development Goals. The NTB strategy puts an end to many more things that are entrenched in the way we have been doing business over the past decades. And for the new elements of the strategy to take roots, some old policies, some practices, and some perceptions will have to be abandoned. And let me highlight as examples a few important ones that apply to the three pillars. Now first, through pillar 1, the NTB strategy puts an end to what has been for all these years too passive an approach to detecting TB cases. How conscious and responsive are we to the many hurdles that have to be crossed before finding even a straightforward case of tuberculosis? First, a person has to develop symptoms that are typical of TB. Then the symptoms have to be bothersome enough for he or she to take action. Then resources and circumstances permitting, he or she has to present to a health facility with those symptoms. Then the attending provider has to be sensitive and responsive enough to take the correct action of sending the person for the right investigations and at the right place. And all this has to happen even before we make a diagnosis of TB. Now, evidence shows that year after year, many of these hurdles have continued to persist. And evidence also shows that strict adherence to some simple protocols can substantially improve case detection. The new strategy, therefore, enhances the responsibilities on the supply side, on the care providers. All health workers and care providers will now need to inculcate new habits of actively looking for TB, not just among those with typical symptoms, but also those with greater risk of getting tuberculosis. The undernourished, the diabetics, the elderly, the smokers, the alcoholics, and so on. So more active case detection within the health facility among the people who are presenting to the health services. A step beyond that, and what is also another element of the new strategy, would be getting out of the health facility and actively looking for cases. And there are excellent guidelines now available, which have been lauded by the British Medical Association. But please remember that the NTB strategy does not abandon passive case detection, nor does it push aggressively for indiscriminate active case finding. All it does is put an end to the laid-back attitude and approach to detecting TB cases. Second, and also through the pillar 1, for far too long there has been disproportionately greater focus on diagnosing and managing sputum smear positive TB patients. The NTB strategy puts an end to that too. TB patients, regardless of their age or type of disease, smear positive TB or smear negative TB, extrapulmonary TB or pediatric TB, HIV associated TB, or however demanding it may be, drug resistant TB. All patients have a right to receive care free preferably, but certainly at a cost that they can easily afford. And a third important practice, or rather non-practice, that the strategy puts an end to, also under Pillar 1, is our long neglect of preventive treatment of latent TB infection. Preventive treatment of contacts and people with HIV has long been recommended but also neglected, particularly contacts. And we know that we now have guidelines for the treatment of LTBI, which were again released on the Global TB Symposium Day, and we now need to put them in practice. The fourth key message is related to Pillar 2, and it is critically important. The End TB strategy puts an end to a strong perception which has also led to policies and practices which presume that TB control is exclusively the business and responsibility of national TB programs or equivalent bodies. Now, this must no longer be the case. TB control cannot be and should not be a monopoly of TB control programs. No doubt there have to be national TB programs or teams at the national level, at the subnational level, for coordination, for monitoring, for support. But well-defined and specific contribution to TB care, control, and prevention has to come from a whole range of stakeholders across the health and social sectors, from relevant ministries to affected communities, and from civil society to private providers. Now, this is as important for collaboration as it is for regulation. For example, those responsible for planning and rolling out universal health coverage, those designing and implementing social benefit schemes, those addressing food insecurity, those concerned about the growing menace of antimicrobial resistance, or those responsible for infection control or communicable disease notification systems or vital registration systems, all of them must not only be approached, engaged, and made aware of the crucial role that they can play in TB care and control, but also supported adequately so that they can carry it out. And a good indicator of this happening would be the proportion of people not directly working on TB attending conferences like this or meetings organized by WHO and other partners. So in short, the End TB strategy also envisages an end to the insensitivity, if not ignorance, about TB among many stakeholders that can significantly contribute to TB care, control, and prevention, but still remain unengaged and therefore unconcerned. And finally, the End TB strategy puts an end to the notion that we could end the TB epidemic as the rich countries did by achieving universal access to health and TB care and by adding social protection measures to it. Well, that of course is essential, and that could certainly help meet some major milestones on the way, but an end to the TB epidemic within our proposed time frame of just 2 decades will not be achieved without new and better tools of diagnosis, care, and prevention. So can you suggest a better label for a strategy that ends the current excessively passive, laid-back approach to finding cases, that ends the discrimination among different types of TB patients, that ends the neglect of preventive treatment, that ends the misperceived monopoly of TB programs in tackling TB, and that ends the long drought of new tools, all these to finally end the TB epidemic. Now, doesn't that make End TB strategy an appropriate level? So may I ask now, how many of you are okay with this label, the End TB strategy? Can you raise your hands or give me a shout, please? Thank you very much. I think I can begin ending my speech. So this is again one final time for you to absorb the full strategy at a glance with all that is new shown in blue. Now this graphic, which you may have seen before and you're going to see it umpteen number of times, which is also very much a part of the strategy document, captures how things could unfold epidemiologically over the next 2 decades, of course, if and only if the end-TB strategy gets implemented as expected. So the current decline of the TB incidence is even less than 2% a year. Now, mostly rich countries have accomplished the 10% fall per year, which now the whole world has to achieve up to 2025. Now, this looks like a tough call, but the ground reality is in our favor, and that is globally a much larger proportion of poor populations which harbor the greatest burden of tuberculosis live in low, middle, and middle income countries than they do in poor countries. So progress in these countries with the highest burden, such as India, China, Indonesia, in Asia, for instance, or South Africa and Nigeria in Africa, for example. So the progress in these countries will greatly determine or will tell us whether or not we can achieve these targets. And if you had any doubts on our minds about this possibly happening, I think the Honorable Health Ministers of India and South Africa have reasonably succeeded in putting many of those doubts to an end. So, to end the TB epidemic, of course, we will need the technological breakthroughs. And this will likely happen only with substantial investments in research and development, not after 25, but now. And I would like to emphasize here that the optimization which we see, optimization of current tools, will surely require innovation across the board, and I'm delighted that that's what exactly we are going to listen in the next plenary from Aamir Khan. The e-health, the m-health, that's what's going to, I think, help us take leaps. Now the strategy is supposed to come into effect post-2015, so what do we do now? Of course, earlier we begin the better, and we should all use the time in the run-up to 2016 to prepare countries to change gears so that they begin their long journey with conviction. And WHO is currently working on developing some broad guidance to help countries in adapting and implementing the strategy. And this guidance document will essentially be a bridge between the strategy document endorsed by the World Health Assembly and the numerous guidelines and tools that are available now or that will be available in future. And this is what we plan to follow in the broad outline. For the overall strategy, there will be guidance on how to adapt the strategy and the targets to the country context, and a list of indicators to measure and monitor the progress and impact.
Dr.
And for
Uplekar, 2 minutes, please.
Yes, and for each pillar and component, the document will outline the following: the policies that should be in place, the key actors within and outside the health sector to be engaged, the requirements from the system, the key implementation steps. What will be important is to give practical working examples from the ground, from countries, and also provide links and citations of useful resource material. But this is all theory, and we will get the fruits if there is concerted action in countries and within countries, action where it matters most. And as we all also join the countries in their long journey to help make a real difference, and as you all make your own mark on this beginning or the end of the TB epidemic, I would like to leave you with two thoughts. The top one by Albert Einstein is especially for those who will be busy adapting the strategy, and the bottom one especially for those who will be implementing it. Thank you for your attention.
While we're changing speakers, I would just comment that in this first Riley Symposium, I would be remiss not to mention that the word transmission, I don't think, appeared in the strategy, although infection control did. We were talking about preventing disease, but maybe not preventing transmission in crowded ambulatory settings, et cetera, and I think that's something that needs attention.
Yeah. Thank you very much for your intervention. I I think that we have to be really ambitious to end tuberculosis, and as you mentioned in your presentation, we really need new tools. And for these new tools, we actually need to triple funding on research and development. Just a thought that we all have to fight for this tripling funding. Now we are going to share this moment with Dr. Aamir Khan. He's from Pakistan, and he's the Executive Director of IRD. Thank you very much.
Thank you. Thank you, chairs, and thank you for all of you for coming. I'm delighted to be here to honor Professor Riley, upon whose work we all build and with whom I shared an alma mater as well. I'm going to speak about new models for lung health and diabetes care in the private sector. And I'm going to have to go pretty fast, I imagine, Ed, because we don't have all the time I thought we might have had. But this is really work based upon a TB Reach, built upon TB Reach project that we implemented in 2011 in Karachi, targeting the private sector and mass screening at private clinics, and identifying suspects, sending them off for a sputum test, and then reporting them, notifying them to the NTPs. We doubled case notification through that particular intervention, and then built upon it, first by sort of really thinking through what the impact might be of a potential sustained intervention scaled over the next 5 years. And we modeled this with David Dowdy and his colleagues at Hopkins. And the data suggested that there might be a cumulative percentage reduction of about up to 50% over 5 years in mortality from TB in our communities, or in Karachi City, a city of 20 million people, if we were to sustain that intervention and scale it up. In fact, we've been doing exactly that, and with a series of TB Reach projects, in fact, 3 TB Reach initiatives implemented in Karachi, we've been able to identify, along with our base Indus Hospital program, over 17,000 TB patients, and notify them to NTP, and have a modest impact in terms of our treatment success rates as well. At some point, in 2012, we asked ourselves, well, it's really nice to have TB Reach and Canadian taxpayer monies to be able to run and make all this additionality in terms of cases in your communities, but how do we sustain this beyond the TB Reach support that we might, that might end anytime soon? And so we began discussing options about where else are the sources of funding available to us in the country. And in particular, we looked at out-of-pocket expenditures. In Pakistan, there's an estimated $5.5 billion that were spent in 2011, 2012 on health. Over $2.5 billion possibly came out of private sources and out of our patients' pockets. And so the question we ask ourselves is, why are we so focused on that particular donor component? Why can't we access the money that our patients, including our poor patients, are already paying when they seek care in the private sector? And other data suggest that up to 70, maybe even 75% of all first-time healthcare visits are to a private provider. So we came up with the thoughts around a social business model. So how is a social business model potentially distinct from what most of us are familiar with, the grant model? The grant model, you receive money and you spend money. In a social business model, the objective is to develop a revenue stream which allows you to sustain at least the core operations of what it is that you're doing. And these revenues aren't shared as dividends among private investors. They're in fact reinvested into the social business to expand your programs. So thankfully, at that time, we were able to work and partner with the TB Expert Consortium, and as part of the TB Expert Public-Private Mixed Social Business Project, with focus on 3 countries, Pakistan, Bangladesh, and Indonesia, we were able to access a large number of gene expert machines and cartridges, the commitment for the cartridges. And with the Stop TB partnership and its TB Reach program, access TB Reach funding to implement these social business models in Karachi, Dhaka, and in Jakarta, all 3 large Asian megacities. I'm going to actually focus on one city, the one that I think is best perhaps progressed at this point, but I did want to summarize the TB component because I know everybody's interested. So here's a snapshot of what we've achieved under the TB Expert PPM project, the one that's targeting the private sector in Karachi, Dhaka, and Jakarta. And I want to acknowledge our partners in Dhaka, ICDDRB, and Dr. Sarah Bano, in Jakarta, PTEC, led by Mr. Roy, and in Karachi, our team now led by Imran Zafar. In red, I've highlighted those numbers that I think are most important on this slide. There's about over 65,000 patients that we've tested using the Gene Expert, identified over 9,000 patients. and 687 MTB RIF-positive cases, so RIF-resistant cases as well. In one particular setting in Jakarta, we continue to have a challenge with putting these patients on treatment, and we continue to address this. I think part of that comes from the fact that both Karachi and Dhaka have had previous TB Reach funding and support, so we were geared to keep making sure that all of our patients were put on, but just wanted to know that that is a challenge in one of our sites. So what does this social business model look like? Well, in Karachi, we have mass verbal screening at private clinics, hospitals, even some laboratories. And the verbal screening is essentially a community screener who's asking a few questions about symptoms, entering that data into a cell phone, offering a 50 rupee or 50 cent US dollar cents test for glucose screening at that point of care, at that clinic. If a patient is a suspect, or if they test positive on a random blood glucose, they can also then be referred to a testing center, a screening center that we've established as a social business. At that center, there are other tests that are available. One is, of course, for free. The TB expert test is completely for free, always is, in Pakistan. And then there is also the a CAT4TB system associated with computer-aided detection for TB, the digital X-rays, which allows us to determine whether a chest X-ray is abnormal or not on the spot without the need for a radiologist. And then we also do spirometry and offer glucometer-based random blood sugar screening. Patients that are unable to pay are always referred to other PPM sites, including Indus Hospital and other public sector facilities where we've put in the gene expert and similarly offer the same services, but minus the CAT4TB spirometry to these patients who can't pay. So this model, because we're focusing on sustained systems, sustained programs, is really building upon revenue streams for patients that can pay. When we put patients on treatment, those that have TB or those that are drug-resistant TB, they always get free treatment. For diabetes, if you're taking oral treatment, it takes about US $2 per month to keep that patient on treatment, to start them on treatment and to keep them on treatment. For more complex COPD, and I'll show you some of this data, and diabetes complications, we refer them to consultants if they can pay, to private consultants if they can't, to places like the Indus Hospital or other public sectors. I'm not going to spend too much time on this particular slide, especially given the time, but I just, we're using IDF-based clinical guidelines for testing for diabetes in limited resource settings. So this is essentially a glucometer. We try to focus on getting a fasting blood glucose, but some patients don't have the time or will only come for that one visit, and we can also determine if they have diabetes based on that single test, although that's not our preference. We also do bidirectional verbal screening for TB and diabetes. We provide point-of-care testing, treatment, etc. So in that bidirectional, when we screened over 1 million people, and I'll come to the reason why we have the 7,000 diabetes suspects, but these 7,000 diabetes specifically are those that are above 45 years of age, that have a BMI of 23 or above, and that have a family history of diabetes. That was some of the discussion that we had with the private providers because they were at the onset unwilling to consider everybody, the broader criteria that we wanted to use perhaps for our algorithm. Of those individuals, just over 2,800 were willing to pay for the test. So this is important. This is not a research study. You don't have a smooth, one box to the next. These are patients that are willing to pay. And amongst those 2,800 or so, 1,181 were diabetics, 28% of them were newly diagnosed, and the other 71% were already known diabetics. Amongst these patients, 160 were considered suspects for TB as well, and from them, 38 ended up paying for the chest X-ray and then were tested on the expert. 15 of those 38, 15 were MTB positive. In a small subset of patients that came to one of our clinics, some of these programs are more recent. We've focused on getting the TB program up and now have started introducing the diabetes and the COPD screening more recently in the project. We're looking at the data for the first 287 at one particular center. The first 287 MTB positive patients, about 5% of them had either diabetes, newly diagnosed diabetes, or they had pre-diabetes. It took 19 MTB positive cases to identify a case of diabetes or pre-diabetes. You had to test 19 MTB positive cases in our setting to identify one case of diabetes. We were also screening for COPD in our population, and here we used the GOLD criteria. I won't go to the details here again, but again, there was symptomatic screening in the community. Patients were referred for TB. With those who had TB or COPD suspects, we referred to the screening center. We did a CAT for TB, did an X-ray, we did gene expert testing and spirometry testing. This is the gold standard spirometry testing with the pre-post dilatation test, etc. And then if patients were found to be sick, then they were, especially those with COPD or restrictive disease, they were sent off to, referred off to consultants. So again, amongst the over 1 million people that are verbally screened, those that had all of these symptoms, cough, shortness of breath, wheezing, or a smoking history, we identified over almost 1,900 COPD suspects, 15 to 16% of whom were willing to pay for the spirometry. Amongst those, 296, 77% had an abnormal spirometry result. And among those that were abnormal, 13% were detected, had TB, had MTB positive TB on an expert. For those of you that are interested in this particular pattern of disease that we saw on the COPD, on spirometry, we were looking for COPD. We, in fact, found more restrictive and mixed pattern disease. And I think that just reflects the prevalence of TB disease and the advanced disease in some of the people that we were screening. Up to 60% of the abnormal results were restrictive, and another 30% almost mixed pattern disease. So, well, where are we with the social business model, right? So, the cash balance of a grant looks something like this, yeah? You spend your way down this happy curve, and you're very often pleased with yourself and your outputs. A social business model, when you're down here at the curve, is really something like the valley of death. It's a very, very different place to be, because you're spending money and you're trying to figure out how to keep these revenue streams growing and how to find new revenue streams. And it's in some of these challenges, and I think certainly our groups, but our donors, Unitaid, Stop TB Partnership, and others, in their willingness to take these risks with us and to dare to sort of try something that's different, we continue to look for new solutions. And not all our results are, on that front, are as bad as I might make them seem right now. So here's something that we've really worked on in Karachi in particular. This is a commercially available device that's now being rolled out by the largest distribution network in Pakistan. It focuses on small shops, pharmacies, even GP clinics and hospitals through our program. And it allows for us to integrate our program and our services into the regular economy, the businesses that are the business ecosystem that exists, where even our poorest patients come and use them. And I'll explain that in a moment. But the device itself allows you to house a phone of any size. It has a magnetic strip reader, it has a card, it has a chip card reader, it has a near-field NFC reader. You put a fingerprint on it, and you can identify a person. It communicates with a cell phone back to a server, whether a national database or a project database. It confirms who's standing in front of you. If you've given them an ID card, it confirms this person is with you. You can take cash payments. You can top up phone cards, etc. with them. Why is this important? Because when we are currently looking at our revenue streams, we have focused on comorbid conditions along with TB. So we said, can we maybe generate the revenues that we would like to sustain our business, social business with, by testing for patients with TB and, with diabetes and COPD, and then offering them treatment. We think we can. But what's possibly limiting is that we can only sustain our current operations and not scale. And so what we must do to grow is to sort of integrate ourselves into the existing networks. And so what is this system? So this system, it's called Batwa or Wallet, is a client verification and payment service. You can issue and verify client ID or card with it. You can provide, we are now going to begin to provide access to a wider range of laboratory testing for these private providers through the system. You can verify in Pakistan a national ID card, but that system could be set up in any country. You can open and use, any person or client that comes to you can open and use a bank account. They can pay their utility bills. They can top up their mobile phones. And there's an existing health insurance, a micro-insurance copay system. So for the first time, an opportunity came to us presenting itself in a commercial service that's already being rolled out in the country, and we hooked ourselves onto it. Again, trying to think through and working to develop what the revenue streams are going to be. So what have we learned? Expanding screening to diabetes and COPD when you've been offering free screening for TB and treatment, and now asking for a fee-based model for the diabetes and COPD is more challenging than we had anticipated in these private care settings, largely because the TB program is something that's familiar to many of these providers. There is no equivalent of a lung health disease program or a diabetes program, and so many times the GPs question our intent. Why is it that we're doing this? And their risk of potentially losing their customer base because a lot of their patients have respiratory symptoms, chronic respiratory symptoms, or are diabetic. And so, of course, we never refer a patient out of the system without their consent, and in fact, everybody that we screen and is determined to be positive is sent back to the clinician, the treating GP. We are also beginning to both believe that chest x-rays should be free for patients that have TB or TB suspects. Because the chest x-ray is a revenue stream, but there are many other ways. The TB patients, there are too few of them perhaps, and who are willing to pay, and they're too poor or they're too poor. So there are other ways for us to generate revenue, and our comfort with that is now better than it is trying to generate revenue just from a chest x-ray. We are very comfortable with the idea that our business operating costs can be covered through increasing the revenue streams from the diabetes and COPD component, as we had originally intended, but also now expanding to a wider range of laboratory tests that our GPs and hospitals are now asking us to provide them. To scale the social business, we will need to think bigger, and we will need to integrate with consumer services of the type that I showed you, that poor patients access routinely in their daily lives. So thank you very much. I just wanted to acknowledge all our contributors and partners.
Thank you, Aamir. I don't see microphones. We do have a few minutes before this session ends. I don't know if there are any questions and if there's a way to be heard. If not, I thank our speakers and for the session, the first Riley Symposium, and wish you well.
Please remember that you can sing on the petition to triple the funding for R&D. My community friends are outside, so please sing it. We need more fun and funding.